We shall start the session now.
Yes,
So,
yes,
the
yeah.
topic for today is case based discussion of acute CVA, and the class organizers are Dr. Aklesh Tandekar, Dr. Gunadhar Padi, and Dr. Asif Iqbal. And for today's examiner, we have Dr. Yash Javeri, who is a director and head at CCM and EM Regency Health, Lucknow. And the case presenter we have is Dr. Rupan Bhadury. He is a DRNB critical care resident. And the moderators we have here is Dr. Payel Bose, who is a senior consultant critical care medicine in Medica Super Speciality Hospital, Kolkata. And also we have Dr. Tanmoy Banerjee, who is a senior consultant and director Medica Super Speciality Hospital, Kolkata. He will be joining us soon. Thank you. Sir, you may start.
Very good evening to all my respected teachers already present here. My case today is on acute CVA. So let's begin with the case now. So the patient is a 20-year-old male who was admitted with complaint of sudden onset slurring of speech with bleeding of saliva. He had sudden onset progressive right-sided weakness. There was no history of loss of consciousness, seizures or trauma. It's a known case of hypertension, obesity, and ischemic heart disease. PTCA was done in 2021. A known case of CA. On examination, he was hemodynamically stable. The BP was around 130/80. Situation was maintaining at around 100% without any support. He was a bit drowsy. There was global effect. Right-sided contusion both on the upper limb and the lower limb, and the GCS was E3, V2, and M5. So on examination, the right plantar reflex was upright. So the DD that we thought at ER at that point of time was stroke. It could be ischemic versus hemorrhagic, or other kinds of stroke mimics, or transient ischemic attack, or intracranial as well. So depending on that, the ultimate diagnosis that came out to me in the patient was acute ischemic stroke. On the after the CT was done immediately, and the CT angio was also done, which showed cutoff after the M1 segment of the left MCA. So this is the exact picture of the CT angio, where we can appreciate the cutoff at the level of M1 around and M2. So the patient was fortunately the patient was presented within 2 to 2.5 hours of the stroke symptoms. So it was within the window period, and thus patient was admitted in the ER. The emergency stroke team also came and examined the patient. So here is the exact CT scan on the upper end, um, and the CT angio is in the middle side, and the stroke was quite large enough to compress the carotid, as we can see here. And there was kissing carotid presentation here, and the art was difficult while examining the CT angio. So that he was initially admitted under neurologist, but since the NIHS's score was more than 25, he decided not to go for thrombolysis and plan for mechanical thrombectomy, which is not very common in our setup. So patient was on ecosprin, but it was immediately stopped for the procedure, and mannitol was initiated considering the edema, anti-edema measures for that, and he was opted for endovascular mechanical thrombectomy, which was done by our intervention radiologist, Dr. Nirmalo Rai, and the needle prick time was within 1 hour arrival from to ED within, and the window period was done within the window period by the intervention radiologist. Sorry. The post procedure, the GC was hello.
Continue, please.
Yes, sir. So the post procedure, he was shifted to the ICU with the GCS of E3, V2, M4, and clopidogrel was restarted, not immediately, but after a day. He was already on ecosprin previously. Ecosprin was stopped before the procedure. Now, this was the image done during mechanical thrombectomy. It was done using a device called RED 62 by our intervention radiologist. Here we can see the tortuous vessels, so it was very difficult to get into the MCA. And after the aspiration, the thrombus can be seen here on the left lower side. And then patient was shifted in the ICU. So why mechanical thrombectomy over systemic IVT? So there's more effective therapy with higher rates of revascularization and recanalization, and reduced rates of long-term functional dependence in acute ischemic stroke patient with LVO. And extended therapeutic window is seen up to 24 hours in cases of mechanical thrombectomy, and it can be done in alternative to patients with LVO who have contraindications to the use of IV chemical thrombolysis. So after the procedure was done in the ICU, so the indications for mechanical thrombectomy here are the age greater than 18, pre-stroke modified Rankin scale of 0 to 1, NIHSS score of greater than 6, aspect score more than 6, and causative occlusion of the IC or the proximal M1 middle cerebral artery. And the treatment can be initiated even within 6 hours of symptoms onset. So by in dawn and diffuse, we have seen the it can be done extended up to 24 hours, and also the function, and in that cases, the functional outcome was improved in 90 days. So it is a very recommended procedure if thrombolysis is contraindicated, or it can be done along with thrombolysis. So patient eligible for IV alternatives should receive IV alternatives even if mechanical thrombectomy has been considered. But in our case, it was not done considering the high NIHSS score, and the patient was already on equal. And so on day one, he was drowsy but arousable. The GCS was around E3, V2, M5. Pupils were reacting to light and bilateral equal. The right upper limb, the power was 1 by 5, and the lower limb power was 3 by 5. And the distal pulse was palpable. So on day two, his GCS suddenly worsened. It became unarousable and drowsy. Repeat CT scan was done, which showed a large left MCA infarct but without any hemorrhagic transformation. He was intubated in view of airway protection. So, considering chances of aspiration pneumonia, we started with injection piperacillin tazobactam. So, our referral was also sent to cardiology, who advised a single antiplatelet and a statin. And he was planned to start NOACs after 7 days because the patient also had a ongoing atrial fibrillation on day two. Maybe because of associated sepsis, we thought of. So injection quadron bolus dose and infusion was also continued, which I have not mentioned over here. But he was started on single antiplatelet, and clopidogrel was preferred along with a statin, atorvastatin, 40 mg was started in the patient. And the CT scan did not show any hemorrhagic transformation. So after the intubation, the patient was started on rice feeding, and fluid was gradually stopped because at one point of time he was having basal crepes, and we did a HRCT also. So there was atelectasis on one side, and there was features of fluid overload. So we preferred stopping the fluid, and RT feed was initiated. But since he had ongoing drowsiness which was continued, a repeat CT was done on day 4. So previous CT, then CT on day 2, and again day 4 showed no further increase in infarct size, but edema was present with good amount of NMAS effect. So we knew we would not be able to extubate the patient so easily at that point of time. So we planned for tracheostomy, and clopidogrel was stopped in view of tracheostomy. So on day 5, the tracheostomy was done and MRI was advised. It's not done, but done eventually. So during tracheostomy, we had to give 6-unit RDP because the platelet count was, I think, around 70,000. So 6-unit RDP transfusion was given, and his GCS on day 5, it slightly improved, and the post procedure he was shifted back to the ICU, and ABG showed metabolic alkalosis, and gradually the patient was there in the ICU with tracheostomy. We planned for weaning of the patient, but along with the CT, which only showed edema, there was no further deterioration in the CT scan except for the aspiration pneumonia we suspected, and also there was TT secretions at the tracheostomy site. So on day 6, we sent TT suction for Gram-Sten CS, and injection tobramycin was started. And now the patient was shifted under critical care unit. So we escalated antibiotics to meropenem because his CRP was around 54. So after shifting to meropenem, we again started giving PS CPAP trial, and MRI brain was done after the tracheostomy around day 6 or 7. MRI done, which showed no significant changes. The infarct size was as it is, and CRP gradually decreased from 28 to 17, and GCS gradually improved over days. He was on supportive care. Chest and limb physiotherapy was continued, and the gram stain culture showed no organisms growth. There was pus, but and there was de-escalation from the ventilator mode to OT support gradually over the next 5-6 days. The MRC score on day 12 was 45, which was quite high compared to the previous one. And oral diet was started with sips of water, and the supportive care was continued in the patient. And he was also mobilized with assistant on the day before admission. And the patient was finally discharged with atorvastatin and Eliquis 2.5 BD. And condition at the time of discharge, his GCS was very well improved. He was E4 VT and M6. The power in the right upper limb was 3/5 and the lower limb was 5/5, and the TT was kept in situ. And it was in the next visit where the tracheostomy tube was removed, the Riles feed tube was removed. He was in under home care for 7-8 days, and the Follies was also removed at present. So the patient was admitted in the month of September. So he's a follow-up case of our OPD even now. So at present, here in his last visit in the month of December, end of December, he was able to come with supportive care, and he was assisted, but he was able to walk also. And his upper limb function has improved drastically, and he's actually doing well.
Very nice. Thank you. Is it all?
Yes, sir.
Are we complete?
Yes, sir.
Okay.
Yes, sir.
Okay. One important question which was bothering me from the beginning: why did you start on clopidogrel and not on ecosprin?
So it was a decision made by the neurologist. So they decided to go for combined decision taken by neuro and cardio team, because initially it was an eco-spin for PTC, but since after the procedure, like after 24 to 48 hours, we start with dual antiplatelets here, but they decided to go for single antiplatelet. In this case, they went for clopidogrel.
Okay. 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 We'll go to the initial assessment back. How do
Yes.
you think the initial assessment of a stroke patient differs from other patients in the ED?
So in the ED, most important for the stroke patient is the window period. So we have to keep that in mind. So anything from the patient, he was last seen normal, and the appearance of symptoms, and the patient coming to the hospital. So the time frame is very important. So ideally, the chemical thrombolysis should be done within 3 hours of presentation. So we have to keep this in mind. And also for stroke patient, the pre-stroke tools that I use to diagnose stroke, that is balance, eye movement, facial abnormalities, and an arm drop. So the patient also becoming aphakic. We have to keep this in mind. So, and also rule out stroke mimics and hypoglycemia in such cases. It's very important. So and rest of the things, the airway has to be secured if the GCS is less than 8, and breathing and circulation has to be maintained.
Okay. What initial in Dr. Akhilesh and others are also around? Dr. Asif,
Yes,
Dr.
sir.
Akhilesh, yeah.
Sir, I'm there, sir. Yes,
Okay.
sir. Hmm.
Dr. Akhilesh. So what investigations will you like to do in a stroke patient?
For stroke patient, a routine or investigation we have to send immediately once the patient arrives in the emergency. That is CBC, CRP, because we need to rule out sepsis also, or any.
No, why should we rule out sepsis in a stroke? We need not rule out sepsis at all.
Okay, sir.
Yeah.
So initially,
And see, always
cooperation
remember there is nothing as routine investigations.
Yes, sir.
And if we talk about stroke, we require very few investigations. What are those
Yes,
investigations?
sir. For these cases, first is the CBC, the platelet, consisting of the platelet count, and INR and APTT. These are most important investigations that we need to do immediately. And also think of doing a CT as early as possible.
So PTNR and CT are most important. Obviously, we will do an ECG and RBS also.
ECG and also, yes, sir.
Yeah. Doctor, do you have a stroke team at your hospital
Yes, sir.
or a stroke code?
Yes, sir. We have a stroke code. We have a brain code brain, and we have a stroke team also, comprising
Wonderful.
of the people from neurosurgery team and critical care team, and ER is also present.
Yeah. The assessment in the emergency, the main thing is you have to do an hyper acute assessment.
Yes, sir.
You understand? You have to be very fast and it has to be multidisciplinary.
Yes, sir.
Dr. Akhilesh?
Yeah, any history which is important in such cases? Any particular history or any other comorbidities which may be important?
So,
In case we
first we need to rule out if the patient is on any anticoagulant or any history of pre-existing stroke was there within the last 3 months, or any old history of subarachnoid hemorrhage or aneurysm has to be ruled out here, or any previous history of surgery in the last 21 days, and patient other comorbidities, that is like hypertension, diabetes, association with smoking is there, so we have to rule out whether the patient is a chronic smoker. Uh, and also, if it could be a stroke mimic, so we have to see any cause that can actually lead to hyponatremia or derangement of LFT by hypoxic causing hypoxic ischemic encephalopathy, or any history of paralysis or migraine with aura. So this can also present as stroke. So history of history, this is very important.
Yeah, so it's very important. And what are your, when you examine these patients and you start resuscitating these patients or you try evaluating these patients? So apart from your routine investigations, as you said, you need very particular and pertinent investigation that you have to do. You don't need to do a battery of investigations, but very targeted investigations is very important. So what do you expect in the CT or MRI? Uh, what would be better? And
So
what
of
is
course,
your expectation that you would expect in, when you do CT or MRI or any sort of other investigation?
so
So
usually in our setup, after the patient comes, we do an CT first, followed by an MRI, even though MRI is always available. But to rule out the stroke, whether it is hyperacute or acute or something subacute, it's better to go for a MRI to see any ADC DWI mismatch is present or not, so we can actually get the time period. If cases of wake up stroke or any or to rule out any transient ischemic attack in this patient, so MRI is advisable, but so we should always go for CT scan, because CT scan takes less amount of time, so that as early as possible we can go for thrombolysis in our case. So I would prefer going for a CT scan.
So if you don't have MRI available and you have only CT available,
Yes, sir.
so what kind of CT you would like to ask for?
What kind of CT, as in like,
CT with something, CT with what?
This something, yeah.
so we can go for contrast enhanced CT scan.
Specifically what?
Sir, early signs of stroke can be diagnosed better because MCA dot sign, or any kind of edema, presence of any edema, or can be seen better with the contrast cases. Uh, um,
Yeah, CT perfusion scannings are also very
yes, sir.
important.
CT perfusion scanning is can be done here, sir.
Yeah, especially when your patient is presenting beyond 3.5 hours or so, and you
Yes, sir.
still evaluate
Yes,
the
sir.
penumbra. What is
Yes,
important is to evaluate how much is the penumbra left, and you need to safeguard that.
number.
Okay, so CT perfusion scanning, most of the
Yes, sir.
centers not be available, but if you have a CT, you should ask for it. Okay, but
Yes, sir.
yes, MRI may be a gold standard. MRI stroke protocol can be, quick MRI within, 5 to 10 minutes of important sequencing that you can do, and you can evaluate your patient better compared to CT scan.
Yes,
Any
sir.
other, investigation you would like to do apart from the CT or your basic investigations when you evaluate your patient for stroke?
Apart
Any
from
other investigation?
apart from
You would
CT and
like to
MRI.
know the root cause of, stroke, you would like to do any
So
other?
we can go for a Doppler study to rule out any embolus.
Okay. Doppler, which Doppler?
Carotid Doppler can be done to rule out any presence of embolus in the proximal vessels.
Where else the embolism can arise?
Yeah. Where else?
What type of stroke we are missing still in the discussion?
So embolic stroke,
Cardioembolic.
cardioembolic stroke, yes sir.
So an ECG is obviously must and an echo
ECG and
as
echo is
required.
advised, yes sir.
Desire. ECG is must, echo is desired in most of the
Yes,
cases,
sir.
depending on the case scenario. How does a cardioembolic stroke differs from a normal ischemic stroke? What are the considerations?
Ischemic stroke has a very abrupt beginning, and cardioembolic stroke, it can occur suddenly with a history of any cardiac diseases, or patients is on having ongoing, is a known case of chronic AF, or
No, that does not matter. See, the risk major difference is the risk of bleeding is more in a cardioembolic stroke. So you have to be careful with the prophylaxis. Okay. Going back to our case, we are focusing more on the neuro aspect. What are your considerations as a critical care physician?
so after the patient comes to the ICU, our
No, in the emergency also, as a core team member, intensivist will also be called. So what are your considerations there?
So our first thing is the time period when the patient was
No.
last in normal. We
No,
have
no,
to,
no, no, no. See, obviously that is important, but our considerations and our priorities will always remain same.
yes,
That
yes, sir.
if it is a team, if you are alone, you have to look at everything. But if it is a team, what are your considerations?
So our consideration should be the pre-assessment of the modified ranking score to see.
No. See, suppose you are alone, you are looking at this patient and you have been called. How do you assess? What are the basics? Which we always follow, the priorities. You know it?
We have to start with airway.
Yeah, always.
Yes, sir.
A, B,
Airway.
C, D, E.
Yes, sir.
This
A,
has
B,
to
C,
be
D.
always followed.
Yes,
So,
sir.
why I'm asking this question again and again? What are the considerations in the assessment of airway in this particular patient?
So if the patient is having a GCS of less than 8, we have to think of intubating the patient. Otherwise, if the patient is maintaining, it can be continued. And for breathing also, it's important to see the breathing pattern in the patient. Like if there is apneic spells are present, then we have to consider going for an early intubation.
Yeah, very valid point. So don't look at GCS alone, look at other parameters also. Patient has shock with a GCS of 9, you might need to intubate. A patient with respiratory distress, GCS of 10, you might need to intubate. So look in the patient in totality. What are your saturation targets for a patient with acute stroke?
So around 94 to
Above 90, for anything
we are
above
happy with that.
94
Yes,
is
sir.
good enough. And what will you do for circulations? Will you start some fluid for this particular patient?
So normovolemia should be the goal for stroke patient.
Absolutely. For any patient for that matter.
Yes, sir.
Then
And BP has to be maintained. If the BP goes above 220 by 105, then we have to use antihypertensives. And for thrombolysis, we have to keep the BP below 185 by 100.
so what antihypertensive you will use in this particular patient? Suppose this patient was for thrombolysis, blood pressure was 230 by 190.
Yes,
How
sir.
will you manage that particular reading?
So we can start with labetalol. So labetalol is started at a dose of 5 to 10 mg. It can be escalated up to 20 mg. And if the BP further does not fall, we can give labetalol infusion of 2 to 8 mg for 2 minutes.
So,
So,
do you have any other agents that you can reduce the blood pressure?
Yes, hydrolyzin also can be used up to 5 to 10 mg. Hydrolyzin can
Would
be
you like
given.
to use NTG or sodium nitroprusside for control of blood pressure? You may efficiently be able to control the blood pressure. Would you be?
But we ideally avoid sodium nitroprusside because it causes cerebral vascularization and will further aggravate the edema. So it's avoidable.
and
Yes, that
nitroglycerin also we avoid for the same
Yes,
reason.
sir.
biggest mistake that people do and patient deteriorate after
Yes.
that. So contraindicated. Yeah. So apart from the control of blood pressure, so what are your other targets? You have secured airway, your breathing, circulation, all that is taken care of. And now patient's blood pressure also is controlled with antihypertensive agents. So what are your further goals of action?
The next goal should be to after the procedure is done, or normally after patient comes with acute stroke.
Yeah, acute stroke. Yeah, one of the
So,
important.
yes, sir. Anti-edema measures should be taken into consideration.
Like what?
Would you do anti-edema measure to all the patients of stroke?
No, if there is changes in the CT scan, so we should go for anti-edema measures, and like head up, neck should be in the midline, and also we can go for certain drugs like mannitol or 3% NaCl can be given.
So
What
basically,
will be the,
anti-edema
yeah,
measures will be important when the stroke is more than one third. Okay, when more than one third of the brain parenchyma is involved, you have a large stroke. There you have a very high chance of cerebral edema. But with the minor strokes, less than one third of the cerebral uh, volume which is involved, you don't need to continue with anti-edema measures unnecessarily. Anti-seizure prophylaxis, anti-edema measures are not required for all
Anti-seizure,
patients.
no sir, no,
that is also not required.
no sir,
Yeah. And same applies for neuroprotective drugs. No neuroprotective drug has any
no sir.
benefit.
Yes sir,
So please don't use those
yes sir.
drugs.
So we'll
Would you
see the GCS.
would you like to? Sorry, Dr. Yash, I have interrupted you. You can go
No,
ahead.
no, no. Okay, we were at the circulation. What fluid will you use in this particular patient?
Sorry sir.
Which IV fluid will you like to use? Which
So for
IV
low
fluid?
patient,
Yeah,
we can go for 0.9% normal saline.
yeah. So we should be using some isotonic fluid. Hypotonic fluids are big no.
No,
This,
hypotonic should be avoided. So we
yeah,
go for
it's a big
isotonic
no.
or
It's a
hypertonic.
big no.
Yes, sir.
Perfect. Okay. Going back to our this case, particular case, what history will you particularly take from the patient and the family regarding the timing of stroke?
And we'll ask the patient relative about when he was last seen normal,
Okay.
his previous self without any disabilities. When was the last time he was normal?
And suppose the history is vague or it's a wake up stroke, morning stroke, then how will
In
your
that case,
priorities change?
it is better to go for an MRI to see DWI flare mismatch or any mismatch in the ADC or DWI. You can actually get the time of the stroke because
If
most
the
of the
patient
mortalities.
was found awake at 10 o'clock, so what will be your approximate duration of stroke?
If he's found awake at 10 o'clock, then we have to, it's very difficult to get the time period when the stroke actually occurred.
So, but then
Usually,
you will
if it is a
consider
wake up stroke, it occurs usually at midnight because of autonomic instability or any patient is hypertensive, so it can occur at the midnight. So we have to roughly calculate based on the
So,
MRI.
that's why that is very important. When you
Yes,
have
sir.
found the patient awake, so that is the point of time. If you've seen the patient awake at 10 o'clock and suddenly 6 o'clock you found that he is presented with the stroke, so you'll have to consider the stroke duration as from that time onward, 10 o'clock onward will be the time frame that we considered as a stroke time you know so already 6 hours have gone or something like that. That's why you need to do a CT, and CT perfusion also you will have to do, and you will have to evaluate the duration. If it's an acute stroke, generally within 6 hours you won't get anything in the CT. It is usually picked up after 6 hours of the stroke. You get something in the CT, so probably that's why you need to do MRI. So, but you have to consider when was the patient last found awake, so
Yes, sir.
that from that point onward, you will have to consider the duration of stroke. So that is very important.
Yes,
If the patient was found awake at 4 o'clock in the morning, 10 o'clock he might have slept, but he came for uh, you know he came to drink water at 4 o'clock. and you saw the patient had stroke at 6 o'clock. So your stroke duration is from 4 a.m. onwards to 6 p.m. So 2 hours or something like that. So this stroke duration is very important. Huh? Yeah. Dr. Yes, you can take it.
Yeah, yeah. So, what are the other causes of secondary brain injury in this particular subset of patients?
Secondary injuries, it could be a hemorrhagic stroke
Yeah.
or subacute hemorrhages or
No,
any.
no. Secondary brain injury. How to avoid secondary brain injury in this particular patient?
So in this case, secondary brain injuries can occur due to neuroinflammation and hyperexcitability of neurons. So,
Yeah. So, what
uh,
can you do to prevent it?
we have to take anti-edema measures here, and so we have to prevent hypoxia. So the PaO2 should be kept above 60 millimeter by regular ABG, and avoid cerebral edema by using anti-edema measures. And ideally, PaCO2 should also be optimized.
How
Uh,
much?
Initially, the PaCO2 should be kept around, it should be normocapnic around
Okay. Yeah.
38. But if severe edema occurs, then it can be reduced up to 25 to 30 also.
Or if the patient is herniating, then only we hyperventilate. If the
Yes,
patient
sir.
is not
Yes, sir.
herniating, we do
Yes.
not
No,
hyperventilate.
sir.
Why? What is the problem with hypercapnia and hypocapnia?
So, in hypercapnia, vasodilation cause further aggravation of
Yeah.
vessels, further aggravation of the edema, and hypocapnia causes resulting in vasoconstriction, reduces the cerebral perfusion. So, in that cases, if the ischemic penumbra zone is present, it can further cause damage to the penumbra zone.
Right. What are the other causes of secondary brain injury? Just enumerate them.
And there could be also biochemical changes due to dyselectrolytemia or
Like,
epilepsy, like change in level in the sodium, potassium, and
okay.
calcium.
Potassium will not cause anything to the brain
Okay, sir.
generally.
Mainly sodium.
Dysnatremias.
And
Then
others are seizures, any history of seizures, or like excitotoxic injuries due to release of transmitter like glutamate, and also the cascade of reactions that
common things first, common things.
commonly
Hyperglycemia, hypoglycemia,
hyperglycemia is
fever.
yes, sir, fever.
Okay.
Yes, sir.
Any,
Important, like
yeah.
you have to control the fever aggressively. It can
Yeah.
substantially cause secondary brain injury. Any infections, you know,
Yes, sir.
you can,
Meningitis also, encephalitis and meningitis has to be ruled out. Yes,
any
sir.
infection can be very detrimental. So fever
Yes, sir.
infections need to be aggressively treated and controlled as far as possible. The rest, you already discussed all the electrolyte balance, acidosis, and hypoxia and raised carbon dioxide is very harmful. So you have to keep checking this and try to correct this as early as possible.
Yes, sir.
And this,
When
please.
will, yeah. When will you start feeding this patient?
If the patient is not intubated, uh, we have to give a referral to the speech and swallow therapist to see any patient is whether able to swallow with the test, and if that is okay, we can start with sips of water and initiate small feed.
No. Sorry, can you repeat, please?
In this case, we can start feed after giving referral to speech and swallow therapist, and give trials of small feeds of water, and if the patient is able to swallow without any aspiration, and then we can start with feeding. But ideally it should be kept NPM after if the patient is getting drowsy, or is there any chances of hemorrhagic transformation, or patient having a deteriorating GCS, or there is pupillary dilatation or anisocoria. In that cases, patients should strictly be kept NPM. Otherwise, we can start with feed after the patient is having
We do a dysphagia assessment as soon as possible.
Yes, sir. Yeah.
Okay, second thing is rise to feeding will be required. This particular patient,
Yes, sir.
obviously, this patient is not fit for an oral feed. Do not start with water. Water is most difficult thing in your routine practice also. Start with something of consistency of jelly, suji ka kheer,
Yes, sir.
ice cream, things like that.
Yes, sir.
Water will cause aspiration most easily compared to all these with jelly-like consistency. Do not start. Many patient places do not have a dysphagia specialist all the time, so you have to do it on your own. There are many ways to do it, video fluoroscopy and other methods, whatever you are comfortable. But ideally, a dysphagia assessment and speech assessment should be done as early as possible. What we generally do for stroke patients also, we wait for say the intervention, or we wait for the basic procedures whatever has to be done, then we start feeding through a rice tube unless it is a very mild stroke and patient has a good cough reflex and dysphagia is not there, then we start feeding as early as possible. Do not delay for unnecessary cause. Hemorrhagic transformation, we cannot wait it for say 7 days for feed to start. So you have to start within say 24 hours or 48 hours as early as
Yes, sir.
possible. Another important thing which we often forget in the stroke patient is what? Who else has to be involved? Yeah. Suppose a patient, yeah,
Psychological assessment and regular visit.
psychological assessment because the patient could have gone hemiplegic. There are so many concerns for the patient. Patient could be the earning member and the dependency and rehabilitation specialist. Rehabilitation has to start as early as possible.
Yes, sir.
Patient might improve after 10 days, but the patient has foot drop and there is a muscle atrophy. So we have to start physical rehabilitation and mobilization also. Mobilization you should consider on every single day in the morning. You should think whether I can further mobilize the patient. When the patient sit on a recliner, can the patient walk with support? So always ask these questions to yourself and push your physiotherapists and rehab people to do more because they're also laid back at times. Yeah. DVT prophylaxis, when are you going to start? In a patient with acute ischemic stroke.
DVD prophylaxis can be started uh, around after around 24 to 48 hours after ruling out any hemorrhagic transformation or any signs of drowsiness in the patient. So it can be started.
For an acute ischemic stroke within
Acute ischemic stroke, we start with mechanical DVT.
sequential compression device, we start. But
Yes.
when are you going to put the patient on a chemical prophylaxis with an enoxaparin or whatever you want to use? For an acute ischemic stroke patient.
For we practice mechanical device only, but after repeat CT we confirm there is no deterioration. We can start with injection low molecular weight heparin after 48 hours.
And for a hemorrhagic stroke, when are we going to start?
Hemorrhagic stroke. We go for mechanical only. Otherwise,
no. After a certain while, we start.
Okay, so
yeah, generally after say 10 to 14 days is the duration. And most of the times for a hemorrhagic stroke, we'll do a repeat scan and look at the risk benefit with enoxaparin. Then only we start. And we have to start ecosprin, not clopidogrel. I don't know why they chose clopidogrel over ecosprin for this particular patient. For any ischemic stroke, aspirin started within 24 hours. After 24 hours.
Yes.
Okay. Dr. Akhilesh?
Yes. So basically, apart from thrombolytics, any other option that you can offer to your patient with ischemic stroke?
From
You have
thrombolytics, like
thrombolytic Would you like to do further,
Yes,
further, your further strategies for management of these patients?
so we can go for mechanical thrombectomy devices with stent retrievers, that is using solitaire or Solumbra or Penumbra devices, Trivo. It can be used in patients along with medical management because they have shown better functional outcome at 90 days. So we can go for mechanical thrombectomy devices, but the cost is a factor because devices are very costly. So quite unaffordable at times, but it can be done.
Yeah, catheter guided therapies are becoming more popular now. Like,
Yes, sir.
for MI, you directly take the patient in the cath lab and you do thrombectomies or stenting procedures. Similarly, for stroke patients with ischemic stroke. So now catheter guided thrombectomy or stenting procedures have also become more popular. These
Yes, sir.
therapies have a distinct advantage of providing more, options, even if the patient has presented to you with after that window period. So even after
Yes,
six
sir.
hours, you can't
6 hours
thrombolize.
also the extended can be up to 24 hours.
Yeah, you can extend it up to 24 hours and offer the most of the benefit that you can provide. So,
Yes,
and
sir.
the distinct advantages of these procedures are you can actually see either thrombus, you can treat, you have better anatomical localization, you have a therapeutic advantage of thrombus section and even stenting procedure can offer a greater advantage compared to thrombolysis because thrombolysis is a blind procedure. You have to just keep evaluating the clinical progress of the patient. But here, when you do uh, angiography, you can actually localize where the thrombus is and probably you can treat then and there only. So it's quite in real time procedure. So escape study has also shown more advantage of catheter-guided thrombectomy versus thrombolysis. But there are many studies, which have shown equal efficacy of thrombolysis versus catheter-guided thrombolysis. And some studies have even uh, shown negative outcomes after catheter-guided thrombectomy because bleeding complications can also happen. It's not like for MI, you can do the procedures in the cerebral arteries because these arteries are vulnerable. They can bleed anytime. So that's why thrombolysis is still a popular and most effective form of treatment that you can offer to ischemic stroke. And there is still a long way to go for catheter-guided thrombectomy or stenting procedures. It has to evolve over a period of time. But when you have a patient with the ischemic stroke, you also have to evaluate the carotids. There may be carotid plaque. There may be a vertebral artery plaque. So, what would you like to do that if that is the source of a thrombus? So, what would you like to do for that?
So CT angio can be done to rule out any thrombus, and the arch from the arch to the vertex, like we do a Doppler study initially, and then a CT angio from the arch to vertex should also be done along. That's to rule out any.
But what will you do? You have a thrombus in the carotid or the vertebral artery. So, what will you do? What sort of treatment would you like to offer to your patient? Okay, so you can offer carotid stenting or carotid endarterectomies can also be done at a later part because if you leave that carotid atherosclerotic plaque just like that, patient may again present with another episode of thrombotic complications and another ischemic stroke. So you have to treat that as well. Okay, whether it is carotid stenting or endarterectomy, whatever, but you will have to treat that also. Source has to be treated. I
So
hope.
as we will discuss, Dr. Akhilesh was telling, we have to individualize treatment also, especially the bigger stroke centers. Now they can choose the patient wisely. If this patient is for systemic thrombolysis, this patient is for no intervention, this patient is for some sort of mechanical devices. intervention neuroradiologists now have a host of mechanical devices and they have their own sort of very complex protocols. If this is the size, this is the location, I will use this device. That is not our ball game at all. So it has to be individualized now. Big thing is this, especially failed patients, risk of bleeding is more, probably they can do better with a mechanical device also at times. Now, why did your patient deteriorate on day 4?
He deteriorated in the ICU, and probably due to aspiration. So the CRP is also increased. So we started with antibiotics. We escalated the antibiotics for that. So otherwise, but for on day 2 he was not having any hemorrhagic transformation. It was just large infarct. On day 4 he was further deteriorating, but there was only en masse effect of and edema was present. So there was no transformation of hemorrhages. So it either could be due to edema that started occurring, or was combined effect of uh, aspiration pneumonia leading to infections.
Will
So
you
we have
not suspect a seizure in this particular patient at this time? Are you doing a continuous intermittent or continuous EEG?
EEG was done to rule out non-convulsive status epilepticus. It was normal actually. There
Okay.
was no change in EEG.
So which patients of acute ischemic stroke have higher incidence of seizure? Overall, the incidence in a small stroke is very less than 5%. But patients with cortical involvement or patients with involvement of multiple lobes are at higher risk. Hemorrhagic conversion, if your
Yes, sir.
patient did not have seizure earlier, now after a few days has, then it could indicate hemorrhagic conversion also. So just keep that in mind.
So
Okay.
So just to add, there are few more trials which have come up. You know, intra-arterial thrombolysis is also possible nowadays because blind thrombolysis sometimes may present with failures. So earlier trials, PROACT 1 and PROACT 2 trials, which were established in 1998-99, has shown significant benefits of intra-arterial thrombolysis in these patients. And there are stent retriever trials also, SWIFT, which was published in 2012, has shown, like you said, solitaire stent retrievers have shown quite enhanced benefits, and successful revascularization was seen. Then later on, you have a Mr. Rescue trial, Mr. Clean trial, Escape trial, and Dawn diffuse trials have also
that's true.
shown stenting procedures to be more superior to thrombolysis. So yes, there is a lot to do in patients who present with the stroke, and yes, it has to be individualized, and the capability of the center. This is possible in high volume centers, but if it's a low volume center, so these therapies may not be possible. Availability of the interventional, neurologist is also very important in such cases. So, how would you prognosticate these patients if patient presents with a disability, and how would you prognosticate his recovery to the family? Because family will keep asking you how would be the progress, whether my patient will be able to stand or use his hand or lower limb. So how would you prognosticate? So what are your aims and objectives, and how would you communicate with the family in such situations?
First, so we'll do MRC scoring on a regular basis to see any improvement in the power and the outcome of the patient. And then a pre-stroke disability like MRS scale, the score should also be kept in mind so we can see how much the patient can improve um, with respect to the patient's background. And
How?
so modified ranking score is important in such cases, uh, which is graded from 0 to 6. So the assessment in the initial admission has to be kept, and regular MRC scoring should be done in these patients, and further communicate to the patient relative about the outcome and improvement the patient is having over period of time.
Yes, fine. That's fantastic. And realistic prognostication may not be feasible all the time because stroke is it evolves over a period of time. You don't know how much the patient is going to recover. So there's yes, but yeah, the prognostications can be done with time frames of 3 months or 1 year or something like that. Usually patients recover, if at all he has to recover within 3 months, because neuroplasticity has its role, and the regenerative procedure sometimes takes time, and usually it is completed by 3 months. But we've seen patients improving even after 3 months, maybe up to 1 year. So initial prognostication duration can be 3 months, but you can definitely say that he may take another a year or so. But rehabilitative procedures, rehabilitative workup is very, very important, especially young individuals. They recover very well. This may not be true with the elderly individuals, but young individuals do improve. So your psychological rehabilitation, nutritional rehabilitation, cognitive rehabilitation, and regular follow-up, physiotherapy, occupational therapies. These are all important aspects of the ongoing treatment that you can offer to your patient. And basically, compliance with the treatment is also very important. Some patients stop taking antiplatelets or anticoagulants, and they may again come back with the recurrence of the stroke. And if the patient is diabetic, the diabetes also needs to be controlled. The comorbidities also needs to be at check, and the compliance with the treatment also needs to be monitored. You can do telephonic or physical, follow-ups with the patients, and make sure that you follow up your patient at least for 1 year to really establish the outcome benefits of thrombolysis or any intervention that you do. So I think that much time frame is very important. Dr. Yesh would like to add. Sorry, I.
Another, no, 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 wonderful points. Another important thing, especially where you see the outcome could be dismal in terms of mortality or lifelong mortality. You have to explain the patient and the family in clear words. Do not use medical jargons, especially the neurosurgeons and neurophysicians. They are very poor at prognosticating. They will never use the word death, and they will never explain the neurological outcome most of the times. So be very, very careful in explaining and integrate your palliative care program also. See, a stroke ICU, almost out of 10 patients, three or four might die in the ICU or in the hospital. So integrate the palliative care program in the stroke ICU early rather than later. That is obvious. Then you start integrating palliative care. It does not make sense. So start integrating them in time for particular subset of patient. And a multidisciplinary care, as discussed from the beginning, is must. As an intensivist, do not be carried away with devices and images. Remember your basic work, collaborate with them, but do not take their role. Follow your processes first. Yeah, what
And
happens in a stroke management, we generally try to take over the images and we start reading the size of angiography intervention, what is needed, clipping is needed, or what. So focus on your thing more rather than on fancy things.
yeah, and we also need to take into consideration the comfort of the patient and quality of life. These are also important
Absolutely.
aspects. If the patient is at a fag end of life, he is beyond 80, 75 years, and he is immobilized, he is going to be bedridden. you know in that situation we need to be really very realistic with the outcomes. If the outcomes are going to be really futile, we need to express this. We should have multiple conversations with the family, and as a physician, as an intensivist, your job is to guide the family in those circumstances, where if the treatment is going to be really futile, our outcome is going to be very futile. You need to probably start a discussion about end of life support care practices also. There is a good scope, and the things have evolved in Indian subcontinent also, where we are still following withholding of the treatment. Withdrawal of the treatment needs a mandate, but yes, withholding of the treatment, and you can support with the comfort care. reduce patients' sufferings, pain, and nutritional. You can continue with the nutritional support and all that. And non-aggressive management should be discontinued, but that should be taking in into the patient's family into confidence. Okay, but you need to read what the patient's family wants. You cannot just initiate on your own. At times, that may be like a double-edged sword, and you may be in trouble. So you need to read what patient's family wants. You need to understand what patient's family's background is. If they are very poor and they can't afford any kind of, they can't afford any treatment, and elderly patients, it's a burden for the families. And at the end, if you keep treating such patients, like the patient keeps suffering, the family also is suffering. So our job is to reduce the patient's suffering, and we need to guide them, whatever, instead of going ahead with aggressive management, which has a futile outcome. We should have initial discussions about this rather than having these discussions later when the patient's family is exhausted financially, and then you start discussion about futility of care and non-aggressive management. That is not justified. So we need to really understand where our patient is going to have his or what kind of quality of life this patient is going to have, and that is very important to have early discussion about futility of care rather than having a late futility kind of discussion. Dr. Yash, do you agree with me?
Yeah, totally, totally.
Most of the times, what happens, we are always on a defensive mode and we keep treating patients and we
Yeah,
try to pacify family and please family and keep giving hope to the family that this patient may, we don't know what is going to happen with this patient rather than speaking such words. We need to really be
perfect.
realistic. Yeah, really realistic and proactive about the patient's outcomes and utility of care. Discussions are also very important, I guess. So, as a human, we are also human being. Every patient has the right to have dignified, time or peaceful journey. But we need to facilitate it well. Most of the times we treat the patient, and then the patients are bedridden. They have bed sores, and they have multiple chest infection. They have contractures, and family keeps spending money on these patients, and then ultimately they become bankrupt. I think we as a physician, we have to take that responsibility and
Absolutely.
facilitate that as well. Yeah, over to you, Dr. Yesh.
Yeah, that is why you have to explain the prognosis clearly, tell them what are the expectations, and they take the final decision. Suppose they have money to spend, there are different types of patients. Some family will require that particular individual even in vegetative state for years. So we have to fulfill that way. Some family will understand that okay, probably the writing is clear on the wall and they will call it a day. We have to facilitate it. So depending on the patient and the family wishes, we have to take the pathway they choose. Yeah.
I think we are well within the time, and we had good exhaustive discussion by
Yeah.
now. And anyone, I mean, there are a few questions in the chat box. Can we take this question? I think lots and lots of questions.
Yes.
So, Dr. Yash, there is one question. When should
Yeah.
anticoagulation be started in stroke patient
Cardioembolic.
embolic origin?
Yes. So the general recommendations again 4 to 14 days for warfarin if it is a small. But if the risk of hemorrhagic transformation is quite big in a cardioembolic stroke, generally we again start after 14 days roughly after an imaging. So for cardioembolic stroke, if it is a big one, we try to delay anticoagulation as compared to an acute ischemic stroke. Do you practice the same, Dr. Akhilesh Tande?
Yeah,
Yeah.
there is one more question. Is it important to do Foley before thrombolysis if patient
Yeah.
GCC? Yes, that's very
Yes,
important because
absolutely.
you thrombolize and you do a trauma while passing a Foley catheter, it will be a disaster and patient will keep bleeding for a couple of days or so, and then there will be a torrential blood loss, and then blood and blood products will be transfused, which again has its own complications. So before thrombolysis, place a catheter, and it should be a non-traumatic catheterization. There is one more question. Good evening. I am arguing from Indonesia. In the case of CVA, when can thrombolytics be given to patients
Same.
who also have renal insufficiency?
No
Dr. Yash,
change.
would like to
That
take-
we follow the same protocol. No change
yeah,
majorly.
yeah. If the patient has renal insufficiency, still we need to thrombolize this
Yeah.
patient. Because after thrombolysis, the patient's neurological recovery is expected. He may have exaggerated bleeding complications or whatever, but then we have to adjust the dose. Probably in patients with renal insufficiency, you may have to adjust the dose. You should not give full dose, or there are guidelines pertaining to that also. For a particular creatinine, how much is the dose required? You should give that. Okay. There is one more question, Dr. Yesh. Good evening. I would like to ask what's the best way to manage acid-base disturbances on acute CVA patients who have undergone a comprehensive therapy with anticoagulation and antiplatelet.
It is as a routine patient, there is no particular difference in acid-based management for a stroke patient or a patient who has undergone thrombolysis. And there are no major challenges. Generally, in stroke patients or neat and clean stroke patient, you won't find any major acid-base
So we
disbalance
need
unless
to
you have introduced it.
Yeah, yeah. We need to find out what is the cause of
Yeah.
metabolic disease, metacidosis, if it is a diabetic ketoacidosis. Sometimes the decay can also precipitate stroke. So we need to treat sugars aggressively. We need to hydrate these patients. If the patient is chronic kidney disease, he may need a dialysis, or he has acute tubular necrosis. We need to treat the acute tubular necrosis part as well appropriately. So these are simple measures and like any other patient, how do you manage acid-based disturbances? So this patient also needs this same intervention that you can advocate. Another question is, hello, I am Arfanda from Indonesia. Thank you for the lecture. I would like to ask, how can bedside clinical assessment NIH stroke scale be optimized for rapid diagnosis in critical care setting? I think it is already discussed. I guess, Dr. Yash,
And
it
you
is
have to
already.
repeat it, repeat it, repeat it. Have dummy patients if you are not having many stroke patients frequently. Check the NIH score, then only you will be in a habit to do it fast.
Yeah. There's one more question. How is the initial management of active CVA patients with history of anticoagulation use? So basically, if the patient is already on anticoagulation and he presents with the stroke, we should consider it as an anticoagulation failure. And we may need to switch over to another agent, especially this usually happens with warfarin. So novel oral anticoagulants can also be used for patients who are on prophylaxis for stroke, like, you have dabigatran, you have got rivaroxaban, and many other anticoagulants that are available, or for that matter, initially you can try even with heparin, unfractionated heparin and later low molecular weight heparin. So these are some of the options that you can use, but low molecular weight heparin or unfractionated heparin cannot be used on long-term basis. So you'll have to switch over to some oral forms of anticoagulation therapies, and we need to find out why patient had stroke in spite of being in anticoagulation therapy compliance, or especially for with warfarin dietary restrictions are followed or not, or INR has been followed up or not properly. So these are all some of the measures that you can advocate while you assess these patients. So what do you think the best sedation for this kind of patients you would like to highlight, Dr. Yash?
Best
Dr.
sedation?
Yeah, Dr. Payal, you can
No,
also,
very good question actually.
as far as the
If
sedation is concerned, what is the
yeah,
best sedation
at
agent in this?
times the patient will require sedation. The most important thing, it has to be under a monitored area, and a relatively senior person should be sedating this patient, not a junior person. Important is to use short acting drugs. Do not use a long acting drug. Use a short acting drug. Most of the time, propofol, midazolam is enough if it is for a small procedural sedation. Avoid long acting drugs. short acting drugs under monitoring we should be using.
Yeah, I think
Yeah.
you have other agents like
And
dextrose.
dexmedetomidine is also quite good, but again, it has to be under a monitored setting whenever you want to use.
But in propofol, yes. So there is
Yeah.
another question. What are the current guidelines for thrombolysis and endovascular thrombectomies in ischemic stroke, and how do they apply in time-sensitive scenario? So I think it has already been discussed, but different thrombolytic agents have not been discussed probably. You have altiplase, tenecteplase, and retiplase also available. You know, I think our speaker can also comment on different thrombolytic
Dr.
agents.
Rupan?
Yeah, I think we couldn't ask this
Yes, sir.
question.
Yeah.
Yeah.
So we can.
Tenecteplase, although the evidence was poor 10, 12 years back, but the evidence has gradually built up.
Yeah.
Yes,
Yeah.
we can start with antiplase at a dose of zero point 0.9 mg per kg. Initially, the 10% of the drug is given at dose over 10 minutes, and then following that, 90% is given over an hour. And then the important thing is BP has to be monitored for the first 2 hours every 15 minutes, for the next 6 hours every hourly, and every 30 minutes, and over the period of 24 hours, it has to be measured every hourly. Other drugs are tenecteplase, that is 0.25 mg per kg, up to a maximum dose of 25 mg can be given. And there was something like this smoke, this like
So basically,
Hello, sir.
you-
Sir,
go ahead, go ahead.
sir. Yeah, yes,
Yes,
sir.
fine.
So, I would like to add something over here that tenecteplase has not been proven to be either superior or non-inferior to alteplase. So, it might be considered in minor neurological impairment where there is no major intracranial occlusion. And another important thing which deserves considerable mention is there are or there have been issues of orolingual angioedema associated with IV alteplase administration. So while giving IV alteplase, we need to be very, very careful that a senior experienced airway manager is present in the vicinity, because endotracheal intubation might be necessary if there is a sudden appearance of angioedema associated with IV alteplase administration. Along with that, we must be taking some routine measures of prevention of anaphylaxis if there is any such evidences of appearance of angioedema or sudden onset of hypotension while we are administering IV alteplase. And as for the blood pressure is concerned, strict monitoring of blood pressure is very, very important, because there has been also incidences of intracranial bleeding even within a period of 24 hours after administration of IV alteplase. So we need to take considerations and supportive actions from hematologists and neurosurgery consultants if we suspect that there has been a sudden deterioration in GCS. And of course, bedside transcranial Doppler and MCA artery imaging. So, this is very, very important besides the clinical assessment for the neurointensivists for detecting early deterioration in the patients with acute ischemic stroke.
Very
Yeah.
valid points.
So, we need to monitor the perfusion, how much the perfusion has improved after thrombolytic agent. There are different ways like transcranial Doppler already. Dr. Payal was suggested that if the patient has cerebral edema, post thrombolysis, patient may deteriorate. Transcranial Doppler can pick up the abnormalities and can help you guide your therapies further. There are other measures like Lycox monitors are also available where you can assess brain tissue oxygen saturation (PbO2). Okay, so brain tissue oxygen saturation can help you to assess whether perfusion related abnormalities are ongoing or not. And you have cerebral microdialysis to also help you whether your therapies are also working well or not. So there are many ways to assess whether the patient is deteriorating, because monitoring of this patient is very important. Post thrombolysis, there are few subset of patients who deteriorate and rapidly develop bleeding and Intracranial bleeding complications are also very high in these patients. So as Dr. Payal said, you know, transcranial Doppler can pick up the volume, velocities, and cerebral intracranial pressure can also be measured, and you can reduce intracranial pressure, in time if you pick it up with with your transcranial Doppler. Any other take-home message, Dr. Payal and
Sir, thank you. Sir, a thing that I thought would be of importance over here is possibly the role of surgical management in a
yeah,
patient with acute ischemic stroke. The Destiny 2 trial, which had said that in older patients with malignant MCA territory infarction, early decompressive hemicraniectomy, it significantly improves the mortality, but it might leave the majority of survivors with a moderately severe or severe disability. So the question still remains that whether we should offer this treatment to the elderly patient with extensive MCA territory stroke or not. And another important thing is in particularly cerebellar infarction. As we know that in the posterior fossa stroke or cerebellar infarction, uh, if there is development of obstructive hydrocephalus, then in that case, ventriculostomy would be a recommended option. And also in cerebellar infarction, where there is significant brainstem compression, despite of maximum medical therapy, preferably decompressive suboccipital craniectomy with dural expansion might be performed. So, uh, surgery, as is mentioned, is not widely required in patients with acute ischemic stroke, but there are certain definitive indications of surgery. But obviously, we should take consultations and advices from our neurosurgery colleagues while managing the acute ischemic stroke.
yeah, Dr.
Sir,
Payal.
what's your
Yeah.
viewpoint, sir, regarding
Yeah,
this?
early decompression versus late decompression in malignant infarcts. Though the long-term outcomes are similar in both these scenarios, but the acute or the early outcome benefits are better with decompression craniectomy rather than conservative approach, because if you go ahead with the decompression therapies, the cerebral edema is also reduced and early outcomes have improved. But it also depends whether your center is high volume or low volume center. And in majority of the times, the high volume centers have shown more benefits of early decompression, even in malignant infarcts, rather than the low volume centers. So majority of these trials which have shown benefits is all in high volume centers rather than low volume centers. But if you theoretically also see, early decompression should be able to offer you more benefits rather than late decompression. So, like in intracranial bleeds, DECRA 1, DECRA 2 trials, stage 1, stage 2 trials, if you see, none of these trials have shown superiority of early decompression over late decompression. But, long term, the 3 month survival and 3 month morbidity and mortality reduction is substantially seen with early decompression rather than later decompression. But if you follow these patients over 1 year or 2 years, the outcome benefits are equal. So that is how we can. It is all individualized approach, because Dr. Yash always said
Yeah. And
Hmm.
more
individual.
importantly, see, in a malignant infarct, it is like choosing between devil and deep sea. So you have to do something, otherwise patient could die. So there we have to offer something in that particular context. Long term outcome is other thing, otherwise the short term outcome will also not be there.
But
Right.
osmotherapy and hyperosmolar agents can also
Yeah.
sometimes be beneficial. Rather than checking all patients for decompression, you should have optimum osmotherapy. Okay, you have 3% saline, you have mannitol, which you can try and reduce intracranial pressure. And later you think about decompression. You know, if your osmotherapy has failed, probably you can go ahead with decompression. But rather than having any osmotherapy or measures to reduce intracranial pressure, switching over to decompression therapy may not prove benefits. Okay, that is what I can say.
Absolutely, sir. Absolutely.
Okay.
So,
We
so there
can
is one
put
more.
up.
Any other
Yeah.
questions?
How do you balance the challenge of maintaining adequate cerebral perfusion pressure without increasing the risk of cerebral edema or other further hemorrhage? Uh, can I read this question because I
Yes,
couldn't able?
please.
Yeah. So there is one question. How do you balance the challenge of maintaining adequate cerebral perfusion pressure without increasing the risk of intracerebral edema or further hemorrhage? Uh, anyone would like to take? So I think cerebral perfusion pressure monitoring is very, very important. You know, brain is localized in a skull, hard skull, where the change in volume to change in pressure, that is what we see in a compliance curve. The compliance depends upon the volume. Any increase in the volume can substantially increase the pressure inside the skull or the brain. You see. So that's why, every attempt should be advocated to reduce intracranial pressure, and that is possible by keeping high mean arterial pressure. If we keep high mean arterial pressure of 90 to 110, even if the intracranial pressure is same about 20 or so, the cerebral perfusion pressure will be kept at around 60 to 70 or something like that. So our target is to keep cerebral perfusion pressure at 65 to 70, mean arterial pressure 90 to 110, and try to reduce the volume inside the skull with the use of osmotherapy. That is what we can. But that is what I can say. I would like to hear from Dr. Yesh and Dr. Payal. Yeah, you can throw some light on this. Do you routinely monitor intracranial pressure, sir? Is there any
No,
recommendation?
there is no need for monitoring it routinely. We use surrogates like a transcranial Doppler most of the time. And in particular subset of patients, suppose it's a large infarct, then only we start monitoring, not as a routine.
Yes.
Same here, sir. We also do not do routine ICP monitoring. We follow the clinical examination and also we use transcranial Doppler, sir.
Yeah, the patients
Bedside. Hmm.
bedside monitoring is more important rather
More
than the
important.
fancy gadgets that we see. Yes, I don't say that it has any disadvantage or it's expensive, it's not available, but we are going away from the clinical tools
So
and these fancy gadgets. We should not fall prey.
I want to add one
Dr.
thing over
Asif.
here. At least the student has to know the cerebral ICP monitoring in details, because in it is important for the viva examination and also the theory examination. So cerebral monitoring, the interpretation of the wave, they should understand.
Yes, sir.
So we are not practicing regular
Yeah, Dr. Asif, I agree with you, but it has to be a continuous monitoring rather than, one or two values like CVP monitoring or pulse pressure monitoring, pulse pressure variation monitoring. Similarly, the intracranial pressure monitoring has to be continuous process. Okay, and then when you have alarming limits, you need to have intervention strategies. Just by monitoring intracranial pressure is not important. You should be able to advocate the strategies to reduce the intracranial pressure. That is also very important. But yes, from exam perspective, monitoring of intracranial pressure is very, very important. There are different ways. Transcranial Doppler, you have reverse jugular oximetry, you have Lycox monitor, and you have cerebral microdialysis. These are some of the different ways to assess intracranial pressure, and the intervention has to be prompt when you have alarming levels of intracranial pressure, which have gone very high, more than 20 or something like that, we need to act on it also. So, yeah, I think we have exceeded the time limits now, but I would like to hear from Dr. Yash and Dr. Payal the take-home message that you would like to give it to the students today.
Okay. My take will be to be thorough with assessment. Do not overdo in investigations, especially in the initial phase of assessment. Have a multidisciplinary team. Focus on your areas firstly rather than jumping into neurointervention, and have a coordinated, well geared up team. That is must. And if the center is not a large volume stroke center, then keep practicing code strokes. Then only the outcomes can be improved. Intubation has to be timely. Basic physiological targets have to be met. Tracheostomy again has to be timely. Do not give an unnecessary extubation trial.
Dr. Yash is not audible. Dr. Yash, Dr. Payal, you have anything to say? Yeah.
Sir, I agree with sir's thoughts. So, absolutely, we do not need to jump at
Any
neuro
role of
interventions.
steroids? You can emphasize any role on steroid because a lot of neurosurgeons they prefer using steroids. Talk about
Steroids,
that.
right, sir? So there is no preferentially there is no role for steroids. Steroids are indicated for reduction of ICP if certain tumors are associated, particularly vasogenic tumors are in those cases decadron or dexamethasone is indicated, but otherwise steroids are not routinely used for reducing the ICP. Rather, maintenance of the normal physiological milieu of the body is of utmost importance for reducing the secondary brain injury and preserving the ischemic areas of the brain which has already not been disturbed. And also, a clinician needs to be well aware of the complications that might be associated with stroke, just like you rightly questioned about early initiation of nutritional therapy, then preventive measures for deep vein thrombosis, and also prevention of pressure sores. Often we find that these stroke patients has repeated admissions to ICU and critical care areas because of this infected pressure sores, and also because of the various Riles tube. There is chances of the sinusitis and also catheter associated urinary tract infections. So device care, catheter care is equally important, and also importance needs to be established to early rehabilitative program. Occupational therapist, if possible, must be the first visit must be initiated during the hospital admission itself once the patient is stabilized. Of course, the psychiatry evaluation is very, very important, because what we find is post stroke depression is an entity, and just like post ICU syndrome, these patients suffer from hypoactive delirium as well as post stroke depression. So, psychological counseling is a very, very important part of the rehabilitative program of these stroke patients. And while discharging the patients, we need to take care of providing patient education along with education to the patient family members. What should be the warning signs when they need to readmit the patients? What are the initial resuscitative measures that can be followed at home, like avoidance of hypoglycemia? What happens if there is seizure? What should they do? So all these things needs to be mentioned. That is, a definitive formulary for the patient education program needs to be provided. The importance of further prevention of recurrence of stroke needs to be stressed upon as well, because sir, as you rightly mentioned, that these stroke patients, the prognostic factors of these stroke patients includes the control of the dyslipidemias as well as the diastolic blood pressure. So medicinal compliance is very, very important. So, my take home message would be, sir, in a case of acute ischemic stroke, we need to approach the patient in a holistic manner, need to take care of the basic physiology of the patient, and while discharging, need to give appropriate education for prevention of the recurrence of the stroke.
So thank you, Payal. Thank
Thanks.
you. Wonderful and very important, you know, update that you would like to give it to the students. Thanks for this take-home message. Dr. Asif, you would like to say something? Dr. Asif, you're there.
Due to some internet issue, he is not here. He was here a few minutes ago, but due to
Okay, then.
internet shut that's
Thank you, everyone. Thank you, Dr. Payel. Thank you, Dr.
Thank you,
Yash.
sir.
Thank you. Thank you.
Thank you,
And
everyone.